Ulnar-sided wrist pain is notoriously difficult to diagnose because so many structures are packed into this one tiny space. But today we're focusing on one of the most mismanaged structures, the ECU, Extensor Carpi Ulnaris. So to understand why the ECU fails, we need to understand its housing. Now what's unique about this tendon is whereas the other extensor tendons are held down by the extensor retinaculum, the ECU has its own subsheath. The tendon lies in a groove on the top of the ulnar styloid. The ECU muscle and tendon is a primary wrist extensor and ulnar deviator. It also works with the other extensor and flexor muscles to stabilize the wrist during gripping activities. Now crucially, the tendon's stability at this point is affected by forearm position. So when your forearm is rotated into supination, which is typically with your palm facing up, this puts maximum stress on the ECU subsheath and causes it to bow slightly, as shown on the screen here. So there's a quick tip for you. If you think you have ECU pain, make sure you avoid full supination. For example, you may find lifting like this is not painful, but when you fully supinate your forearm with your palm facing up, that lifting like this causes some pain. So you can make some modifications to the way you're using your arm and the way you're holding things. Now, not all ECU pain is the same, and we generally categorize it into one of three things: tendinopathy, instability, and tears. Now, ECU tendinopathy is often called tenosynovitis because it's irritation of the tendon's synovial lining. And this is often caused by overuse or misuse in sports like tennis, other racket sports, golf and rowing. The symptoms would include a dull ache, tenderness to touch, and likely some swelling over that sixth compartment. Next, we have ECU instability or subluxation. This is where the tendon pops out of its subsheath due to the subsheath being damaged or stretched. This subluxation or movement of the tendon can often be felt as a painful click or clunk, and often happens when the patient is rotating their wrist or loading in a supinated position. It can occur from a sudden force on the wrist when the wrist is in flexion, supination and ulnar deviation, so perhaps carrying a rugby ball on the chest, for example. Now, I'm in the middle of describing three separate issues to the ECU, but they can, of course, occur in combination. So if you have a subluxing tendon, that can irritate the tendon as well. So you can have a tenosynovitis, that tendon irritation and inflammation, as well as a tendon which is subluxing. So the conditions I'm explaining now can also coexist. Now, the third category are ECU tears. And here we often see longitudinal split tears in the tendon. This, of course, would not show up on X-ray, and you'd need an ultrasound or MRI to detect this injury. So in this next section, I'm going to show you some special tests you can do to help differentiate the ECU problem from a TFCC tear. So the first thing to do is to go down the back of your ulnar and then run your finger around, and you should feel a groove. If you move your wrist around, you can often feel the tendon moving in that groove. Now, if you have pain at that location on the tendon, that's an indication of an ECU problem. And then we have the ECU synergy test. So fully supinate your forearm so your palm is facing up or towards you, then splay your fingers and thumb, and then grab around your two fingers and thumb using your other hand. And before you do that, slightly ulnar deviate your wrist, so move it over towards the little finger side. And then grip around your thumb and two fingers and then try and squeeze them together as you resist. This ECU synergy test is considered positive if when doing this resisted movement you feel pain down the ECU tendon. You can also try some ECU subluxation testing, not as difficult as it sounds. So again, come up the ulnar to the end of the ulnar where the ulnar styloid is, run your fingers over so that you're over that ECU tendon and subsheath. There's a slight indent there, so lock your fingers into that indent. Now, hold your fingers in position whilst you extend and flex your wrist. When you extend your wrist, you'll probably feel the tendon push out a bit against your fingers. That's quite normal. And then the tendon will sink in again when you go to neutral and into flexion. So therefore you can feel where the tendon is. What you can then do is extend and then scoop around the little finger side. They call this the ice cream scoop test. So imagine you're scooping out ice cream. When you do that, the tendon will move under your fingers, but is it subluxing? Is it coming out and around the end of the ulnar? Or is it causing you any particular pain? You can also hold that position. This is a little bit more difficult, but can you rotate your forearm with your fingers remaining over the tendon to see if it pops or clicks or snaps out of place, or indeed is painful? So these are ECU tendon subluxation tests. So following the special tests, it's going to be a good idea to get some imaging done. X-rays won't show any tendon problems, so you're going to need to get either an MRI or an ultrasound. MRIs are brilliant at detecting detailed structural issues, and an ultrasound can be done with movement, known as a dynamic ultrasound, so you can actually see if the tendon is subluxing in real time. Now, in terms of management, a wrist cock-up splint is often recommended because it holds the wrist into slight extension, or a long arm splint may be recommended to reduce forearm rotation, especially if it's thought that that supination movement is causing the tendon to sublux. And immobilizing the wrist in supports like this is usually the first thing that's done to help manage ECU problems. You will of course need to stop doing anything which aggravates the tendon, but of course if you're wearing a wrist support like this, then this will stop you from doing many of those tasks anyway. You may also find some pain relief from getting an injection into the sixth compartment, but you do need to be aware because there's evidence to show that this can also lead to some weakening of the subsheath, which will be very unhelpful if there is already some instability. And if it is determined that this tendon is snapping out, then surgery may be required. Surgeons usually use a lasso technique using parts of the extensor retinaculum to build a new housing over the top of the sixth compartment. This was an educational video. If you think you have any of the signs and symptoms described in this video, then make sure you get some medical advice. You've been watching the Physio channel. My name's Daniel Lawrence. Thanks for watching.